Good evening. I was asked to talk about vulnerable population and COVID vaccination. And of course, in my position, the first group that you think of are people living with HIV. And if you look at the data, there's actually only anecdotal evidence showing that the serological response to SARS-CoV-2 in well-controlled people living with HIV, so people with an undetectable viral load, is actually similar to that of non-HIV infected patients. These are very limited data series. If we go to clinical trials with COVID vaccines, there's actually some information about HIV. The Pfizer vaccine had 120 well-controlled people living with HIV included, but they were not included in the primary efficacy and safety analysis. And their data will be analyzed later. If we go to the other mRNA Moderna vaccine, then there are 176 people living with HIV, but none of them, luckily, developed symptomatic COVID-19, giving us limited information then on this particular group. If we look at the Astrozenica Oxford vaccine, and this is the South African trial, COV005, and there is a specific HIV cohort, but it's not yet analyzed. Finally, the Janssen Adenovirus vaccine has actually 2.8% of participants that are people living with HIV, but they have not been separately analyzed. So this population is present in the trials. We do not have specific information. Some of them have been actually included in the overall analysis. So if there would be a severe alert signal, we would have received it. So generally now, we do consider the vaccine safe for people who have well-controlled HIV infection. We have not particular specific information. We then look at another vulnerable population that has received some attention. Then we're talking about the elderly. And generally, elderly tend to have poor responses to vaccinations. And they have reduced adaptive immune response and different regulations of cytokine production. And the immunosystems render older adults more susceptible to infection and hinders the development of protective immunity after immunization quite often. Also, antibody responses may be lower, but this is not always the best correlates for infection, for protection of infection. For instance, influenza trials have learned to us that even with lower antibody responses, T-cell mediated immunity evoked by the vaccine may be sufficient to protect people. So what have we learned about COVID in general in this adult elderly population? Well, people with age above 65 have a 2.6 higher likelihood of having hospitalizations due to COVID-19 in the US setting compared to people who have ages from 18 to 44. As of December 2020, the cumulative COVID-19 associated hospitalization rate was 1.211 per 100,000 for people over 75 years, and much lower, almost half, for people who have ages from 65 to 74. Also, the risk for COVID-19 associated hospitalization doesn't only increase with age, but also with the number of underlying medical conditions. And of course, people with higher age have often more underlying medical conditions. But we don't have to panic. There is quite some data now about the vaccination about this elderly population. If we first look at the Pfizer vaccine, the vaccine that was actually approved first, it's a vaccine that's currently given in two doses. And if you look at the phase 2/3 trial that's still ongoing, there's an immense amount of people included, more than 40,000. They're randomized 1-to-1 to placebo, and actually quite a large group, more than 42% is over 55 years. And in this trial, the primary endpoints were efficacy of the vaccine against laboratory confirmed COVID-19 infection and safety. And then two-dose regimen conferred 95 protection, as we heard probably before today, in adults. And here you see in this table, you see the different age groups. And what you can see is that actually the numbers are lower with people of higher age. The vaccine efficacy actually stays quite high, but you have to see that in the older age group from 65, especially above 75, confidence intervals tend to be larger. But still, the efficacy is, and the anecdotal evidence in the smaller group looks really, really good. What looks also very good is the side effect profile. Here you see the local events, and here you see the systemic events. And these are the people who are 60 to 55, and these are the people who are older. And you can see there's a trend to lesser side effects in those who are older, which is actually quite nice. If we go to a similar vaccine, also mRNA vaccine from Moderna, also here 2 doses confirmed a really high protection rate against COVID-19. In phase 3, there are over 30,000 people and double-blind randomized 1-to-1 to placebo. And here you see the impressive protection from the mRNA vaccine compared to placebo. The primary endpoint here was the efficacy in preventing symptomatic COVID-19 with onset at least 40 days after the second injection in the per-protocol population. And was very hopeful that efficacy was similar across participants who were elderly, above 65 years. And here you can see, again, vaccine efficacy in this older population is almost similar to the younger population, but again, the confidence interval widens here, especially also because the number is lower of people with higher age in the trial. If we look at specific subgroups in this trial, then they have also looked at people who have severe risk factors for COVID-19, for instance, with chronic lung disease, cardiac diseases, severe obesity, liver disease, or people living with HIV. This subgroup are only people below 65, probably because of low numbers, but they only looked at this particular group. And here you can see at these people 18 to 65 years not at risk, and then these particular risk groups compared to the people of older age. And here you actually see that those people who have severe risk have almost similar vaccine efficacy with the Moderna vaccine, which is really, really hopeful. If you look at the safety and immunogenicity of this vaccine in older adults, there's a small trial, it's open label, only 40 patients was actually added to the original trial with people with age of 56 to 70 years, or really older people with age over 71. And what you can see here is these 2 different vaccination doses, 1 and 2, and you see that the side effects increase with the second dose. And here you see the age groups with the higher age group at the bottom, and actually they're very similar or generally the same side effects. Only for pain at the injection site, you see that people who are older more often complain about that. But in general, actually this vaccine, also in these really higher age groups above 70, is well tolerated. If we look at the immunological response of this subgroup of 40 patients, they were actually quite similar to the responses among younger patients. Here you see the of antibody response to the RBD. Here you see the neutralization assays, and here you see the T cell responses. And in general, here you see the people with 18 to 55, and here you see the older age groups. And this is similar for all the graphics. So the older age groups, and here the comparative group with the younger ones. And actually, in general, the antibody response and the neutralizing antibody response are pretty similar among age groups. And we only see with the T cell response a little bit of dampened response in the older population. If we then go to the Astrozenica vaccine, and this is interesting to know, it's a simian adenovirus factor-based vaccine. So in the general population, we do not have already antibodies to this factor, which is generally a good sign. This trial was done in different countries with different codes. and only 12% had an age above 55 years, and the mean age was pretty young. For instance, the South African part of the trial, the mean age was only 31. In participants who received 2 standard doses of this vaccine, efficacy was generally lower than seen in other trials, 62%. But in participants in the trial that took place in the UK, we had a group that first had a low dose, followed by a standard dose of the vaccine. And there we saw an impressive improved efficacy of 90%. So in this trial, there's a really different situation with different dosing in different countries. Also in South Africa, of course, there's a larger spread of the South African variant that seems to be an immune escape variant. So in this trial, there are actually no age or immune compromised subgroup analysis. If we look into more detail to this Astrozenica Oxford vaccine, we see that healthy adults were actually enrolled in an age escalation manner. So people with severe comorbidities or high frailty scores among the elderly were really excluded. So that means that it's not really at this time point very good translatable to the general population. We also see is that low dose cohort and standard dose group were randomly assigned to receive either the vaccine or a control vaccine in an escalating manner, so that there actually are about more elderly people included. The mean age in the highest age group was here still not that high, 73 only. What was really good news was that here the side effects were less common in the older age groups. Which actually is similar for other trials as well. If we then look particularly at the immunity, then we see that the humoral immunity after a second dose, so these are all the age group with 2 doses, and these are different age groups with only 1 dose. But actually, it doesn't really matter if you look at the neutralizing antibody titers in which age group you are, although confidence intervals widen a little bit for the older age group. If we look at the humoral response to the spike protein, actually we see a pretty similar picture. Ones with only 1 dose have lesser humoral immunity, but all the groups with 2 doses, independent of the age, have a really good response. And the T cell response is a little bit lower for people with a higher age group, as we also saw in the earlier data. But generally, this looks pretty good, also in the elderly. Then there's another vaccine which actually used the Adenovirus Factor. This is a vaccine from China, and it used a commonly called virus, Adenovirus 5. There's quite some in the population to this factor, quite some exposure known. And we have learned from other vaccines that this may be a problem, because if people have already seen this virus that's used as a factor, they may respond less well to the vaccine. This was a double-blind, randomized dose finding, a safety trial with a little small group, only 500 people, randomized over 2 doses and placebo, 1:1:1. And only 30% was over 55 years, so there's only a small group of people really older. What we saw was that already 50% had high and 48 low pre-existing immunity to this factor, which is actually a common cold virus. And also during the trial, there was no SARS-CoV exposure in the country. So that means that efficacy was really not something that could be measured. But looking at the dose finding and the safety trial, at least we could say that people who are older than 55 years and had high had high pre-existing immunity to this factor had relatively low antibody responses. And this was the same for the antibodies to the RBD, but also to the neutralizing antibodies. Although they were still higher compared to placebo. The T cell response was similar among all age groups. So what I'm now planning to do is actually in this group another trial, a phase 2b, where people will receive a second dose. But they really are titrating to the levels of the adenovirus antibodies, because they saw during the trial a boost of the adenovirus 5 immunity. So they're waiting for the best time based on titration to give the second dose. So at this time point, it doesn't look that particularly interesting, but it may, with the second dose over time, improve. Then there's another vaccine that actually uses adenovirus, but this is an adenovirus 26, which has really low seroprevalence. And this is actually the Janssen vaccine. And they performed a placebo-controlled phase 1/2a, randomized for healthy adults between the ages of 18 and 55, but also a specific second or third cohort with people over 65 years of age, which is really nice. This is a much larger group of older people. And they had a pretty difficult trial design with low dose or high dose in a single and 2-dose schedule. But it means a lot of different groups, but it also gives a lot of information. If we first look at the grade 2 and grade 3 events in patients over 65 years, we really see that this is the cohort of the younger people. This is cohort 3, the people over 65. You see clearly a trend to less side effects after vaccination in the older group, pretty similar as we have seen for other trials. If we then look at the humoral immunity, the T-cell response, we actually see a very strong humoral response, both for the antibodies to the spike protein, as well to as the neutralizing antibody, very comparable in cohort 3 compared to cohort 1. And actually a similar picture for at least the T1 T-cell response. So this vaccine looks pretty good in immunity in the older population. They also had the Assemble trial, phase 3, over 40,000 people, double blind, 34% of people over 60 years, which was not in the, this data was only released in a press release. And what we there saw is that 60% effective vaccine in preventing moderate to severe COVID disease, 28 days following vaccination. And there's a pretty big difference between South Africa and the USA, which may have to do with population efforts, but may also have to do with the South African variant at that time was already highly spread in South Africa. Despite this lower protection in South African region, we saw 85% effective protection against severe disease, which is really, really looking good. Also, if we look at the trial, there was quite a big group, 41%, who had comorbidities associated with increased risk for progression to severe COVID, which was, for instance, obesity, type 2 diabetes, hypertension, but also people living with HIV. So this trial were not only healthy people, but really more people from real life situations. So in conclusion, there's a very limited amount of data on SARS-CoV-2 vaccination and people living with HIV, or people with other underlying immunological conditions. But importantly, those people have been included in some of the trials, and we see no safety alerts. So that really gives us a good feeling about including of these groups in the trials, but also an advice for all of us to watch those patients and follow them up more actively. If we look in the elderly, vaccines tend to result in less adverse events, especially in this group just over 65. Maybe we don't know, we cannot really translate it to the really old group, like the 90 years old, and that is something we really have to learn from the actual vaccination outside of the trial. Generally, the vaccines produce an adequate humoral response and also a T-cell response, which is pretty good. but it's still relating to a somewhat lower overall vaccine efficacy, as we know from other diseases. So I think, in general, we can conclude these data confirm that there is an adequate response of all these vaccines in the elderly groups, except for maybe the adenovirus vaccine from China. And that it's a very good choice that we really prioritize the elderly groups because they do benefit from the vaccinations. So thank you so much. This is what I wanted to share with you and hope to see you in real life soon. Bye bye.